Thank you for your interest in our poster. I'm pleased to present the results of an audit performed by the Gastroenterology Department at West Hertfordshire NHS Trust. We were looking to determine whether our current guidelines accurately and effectively detected gastric ulcer-related cancers in an effective manner. Introduction. As we know, malignant change occurs in gastric ulcers and is thought to occur between 2.4 and 21% based on literature studies. We aimed to determine whether we were appropriately following up patients known to have found gastric ulcers and whether they were suitably referred for ongoing investigations and treatments. To do this, we performed a retrospective cohort study for all the patients who underwent an OGD across our trust sites and were found to have gastric ulcers. The data was collected from June 2014 to September 2018, and we analysed any OGD reports, histology reports, MDT meetings and outcomes, and clinic letters to determine whether patients had gastric ulcers found on either the first endoscopy, whether they had a follow-up endoscopy booked either at the time of the ulcer detection or subsequently following MDT discussion, and also whether appropriate management had been undertaken. We found results. We found 449 patients who were identified with gastric ulcers over this period. Of this, only 20 patients were found to have gastric malignancies associated with their gastric ulcers. We should point out that this is different to patients just being detected with an obvious gastric cancer, and we are purely looking at gastric ulcer-related cancers in this study. Of these, 80% of the patients were male with an average age of about 80 years. 60% of these procedures were performed in the outpatient settings, with the rest being performed as inpatient, either as emergencies for upper GI bleeding or for symptoms. We identified, out of the 20 patients with gastric ulcer-related cancers, adenocarcinomas made up the majority, in this case 80% of which, although one signet ring adenocarcinoma was also found. Significant high-grade dysplasia, which when discussed at MGT was treated alongside cancer guidelines, was found in 10% of cases. And of note, one low-grade dysplasia case was also found. In 75% of our cases, a repeat endoscopy was requested at the time of the first endoscopy, although 54% of these were cancelled given the gastric ulcer-related cancer diagnosis. The average time from first endoscopy and identification of gastric ulcer to repeat endoscopy was 37.6 days across all 449 patients. A further sub-analysis looking at whether Helicobacter pylori was present in the gastric ulcer-related cancers was performed, and H. pylori was identified in 15% of those cancers. All of those cancers were referred and discussed appropriately at the upper GI MDT. Based on this study and looking at our practice, all dysplastic and neoplastic cases would have been identified either following initial biopsies and histology review or at the time of a repeat endoscopy, which was arranged at the time of the first endoscopy. We found that 4.7% of gastric ulcers were found to be malignant, which is in keeping with our expected results. We suggest that at the time of a gastric ulcer being identified, a repeat scope to look for gastric ulcer healing is also requested. We suggest that a robust upper GI MDT pathway is established in all hospitals in order to discuss any malignant histological findings at the time of histology review in the context of gastric ulcers. We suggest that the current BSG guidelines appropriately detect gastric ulcer cancers and have a mechanism by which gastric ulcer healing and repeat biopsies can be performed, thus increasing the yield of gastric ulcer related cancer detection. Thank you for your time.